Hello everyone, we are back today with Seizures and Epilepsy Part 2 where we will discuss the drugs, how to approach a patient and the various treatment modalities mainly. So don't be overwhelmed by what you see here. I will explain what is going on. First of all, pay your attention to this diagram here. Now, this is a synapse. As you already know, this impulse is coming and the synaptic vesicles will soon open and release the neurotransmitter. So what is a seizure? It is basically increased neuronal transmission in the brain. So how do we treat that? By stopping the impulse transmission, obviously. So scientists thought that why not block the sodium current? By blocking the sodium current, the action potential won't be initiated, and then obviously the nerve impulse transmission won't take place. So we have these drugs. I want you to remember them as sodium channel blockers. And then scientists further thought that what if we inhibited the release of calcium, which causes the release of these neurotransmitters. So we came upon these drugs. However, these are very non-specific and it's not important for you to remember them. You must have heard of gabapentin and pregabalin in the pain video. You should check that out. So then we thought that once the impulse has ended, the cell is in a state of hyperpolarization due to the potassium current or GABA in some locations. So what if we stimulate the GABA and potassium currents, and then we found these drugs. These are also very non-specific, but I do want you to remember ezogabin, which stimulates the potassium current. Then furthermore, the scientists thought that why not do this for all the neurotransmitter receptors we have. So we got glutamate inhibiting drugs, which include lamotrigine and topiramate. Then this is receptor. This is the GABA receptor, and I want you to remember these drugs, benzodiazepines and barbiturates. They modulate the GABA channel. And there is this special drug called ethosuximide, which blocks the T-type calcium channels present in the thalamus. Now these are briefly the drugs. Now we will move on to how to approach a patient. Now a patient comes with a seizure and he comes to you. So you as a doctor will first look at the vital signs, the respiratory status and the cardiovascular status, and you will treat these if required. Suppose he has cyanosis, which is found in seizure, so you will address that. Then you will try to determine any causes, for example metabolic causes and CNS infections. These are emergency situations. Then you will move on to the history. If this was a first seizure, you will first establish that this indeed was a seizure and not any differential like syncope, which you will see ahead. And then you will try to determine the cause, any precipitating factors, etc., and then you will decide on the treatment. If the patient has a positive history of seizures, then you will try to identify what precipitated the event, and then you will determine any changes in the treatment, whether the drug needs to be changed or the dose needs to be increased. Then a complete neurologic examination is mandatory in all patients who present with a seizure, and then you will move on to the lab investigations. These will primarily help you in diagnosing any metabolic cause, and the standard complete blood count, electrolytes, glucose, liver function test, renal function test, urine analysis and tox screen will be done. If these are found to be positive, you will do further studies with LP, CT and MRI. MRI will only be done if focal features are present, which we discussed in the earlier video. If the labs come negative, then you will move on to the MRI and EEG, which we saw earlier. Now let's move on to the differential diagnosis. Syncope is the major one, which means fainting or a loss of consciousness. Here we will discuss the differentiating factors. So before a syncope or the patient faints, you will see tiredness and sweating and nausea. And before a seizure occurs, aura may be present. This is one differentiating factor. Then post-ictal confusion will be present here. none there. Then muscle sore and headaches will be present in both. So these cannot be definitely be used as a sure shot feature of either syncope or seizure. However, headache is rarely seen in syncope, but there is still a chance. Then convulsive motor activity will only be seen in seizures, and cyanosis and frothing is also very characteristic. In syncope, you will see pallor, and incontinence and biting of tongue is also seen in both, can be seen in both syncope and seizure, however unlikely as it may seem. This is as per Harrison's. And then in case of a seizure, the patient is unconscious for minutes, however this duration is just for seconds. Tonic-clonic movements will be seen for 30 to 60 seconds. In syncope, if they are seen, they will never be more than for 15 seconds. Psychogenic seizure is another differential, and what I remember about psychogenic seizure are just two things. First of all, serum prolactin will help me differentiate. Serum prolactin is increased in seizure, however it will not be increased in psychogenic seizure, and the fact that psychogenic seizure and seizures can coexist independently, so that is also worth remembering. Let's move on to the treatment. These drugs are as per a table given in Harrison. You can check that out. I remember these drugs. These drugs are pretty important. For focal, I remember lamotrigine, carbamazepine and phenytoin. For typical absence, I have ethosuximide. These I didn't find any use for during my exams. So also one must know that when to discontinue, if ever. So if a patient has these characteristics, there is complete seizure control for 1 to 5 years, and there is only a single seizure type. Either general has a better prognosis, and there are no neurological abnormalities, and no family history is present, and the EEG is also normal. Then the doctor can think of attempting to discontinue the drugs after 2 years in a patient who has these characteristics. The doses should not be stopped abruptly, otherwise seizure reoccurrences are high, so they have to be stopped gradually over 2 to 3 months. Now there are surgeries, but these are recommended in patients where medical therapy fails or is ineffective. If the temporal lobe is involved, then we do a temporal lobectomy, which is pretty obvious, but this is the only useful thing I could find in Harrison's. Then there comes the question of breastfeeding if the mother has a history of seizures or is being treated for seizures. So breastfeeding is always promoted. There is a high penetrance of valproate, but still breastfeeding is recommended. Now, in pregnancy, the seizures might continue, they might increase, or they might decrease in number. So one has to remember that the therapy should not be stopped. Valproate has increased chances of causing neural tube defects in children, and for that, if a person is planning for pregnancy, they should shift to other drugs like levetiracetam, which has the least risk, which is what I like to remember. However, if the pregnancy has started, then no drug changes should be done, and valproate, if the person is taking valproate, folate supplementation should be also done. Folate supplementation decreases the risk of NTDs. Now, last of all, we come to status epilepticus. This is a very thoroughly discussed topic, so I won't be covering this here. I will be covering what drugs we give in status epilepticus in another video, but please read this yourself. That is all from my side for this video. If you have any queries, be sure to comment down below. See you next time.